Hey, a very warm welcome to everyone to this Mind Matters talk. Welcome back to the fall season of the Mind Matters series at Mind and Life Europe. As a reminder, our Mind Matters series is a public series, and it is often our most widely attended series at Mind and Life Europe. And it is really a platform for some of the most illustrious names in the contemplative science world and also the contemplative practice world. Some of our past guests have included Mindya Rinpoche, Richie Davidson, Bialan Wallace, Stephen Batchelor, and many, many more. So this evening, we're really delighted to welcome Dr. Willem Kuyken, who is the director of the Oxford Mindfulness Center and the Rietveld Professor of Mindfulness and Psychological Science at the University of Oxford. His work of over 30 years has focused on depression and its prevention and treatment. His work has evolved to explore how we can promote mental health and support human flourishing in the wider population. He's published more than 100 journal articles, including key papers on the effectiveness, mechanisms, and implementation of psychological approaches to mental health. Together with Christina Feldman, he wrote Mindfulness, Ancient Wisdom Meets Modern Psychology, published in 2019 by Guilford Press. And he's currently working on 2 further books for Guilford Press on MBCT for the general population to support well-being. And so this evening, Dr. Kuyken will be sharing with us some of his latest research and reflections on the usefulness of mindfulness-based cognitive therapy and some of the frontiers that this research will be headed into. So thank you so much, Willem, for sharing your time with us. And we will have some time for questions at the end. So if you have questions throughout the presentation, please feel free to note them down and then be ready to ask them after the presentation is over. So the floor is yours. Thank you so much. I think you're muted still.
Thank you to Mind and Life and Mind and Life Europe for this invitation and the opportunity to talk about the work that we've been doing as part of a group over the last, 25 plus years. But I thought before we start, it might be nice just to start with just a settling and coming into our embodied selves as part of the beginning of the talk. So just inviting everybody to just take a moment to, if you'd like to, shut your eyes and just have a sense of turning your attention inwards to a sense of the body, aware, present, dignified, awake, exactly as it is here in this moment. So just choosing to, if you like, come home to the body. There might be a sense of the awareness of the whole body or an anchor somewhere within the body where you can rest your awareness. And more than likely, there'll be the residues of the day which are rippling through the body, which are felt in a myriad different ways throughout the body. Allowing them to be there, recognizing them, allowing them to be there. Just maybe broadening your awareness out to a sense of the whole body, sitting, standing, breathing, being. Nowhere to get to, nothing to fix, no problem to solve just now. Simply being. Sense of being open to whatever's around in the body just now, whether those are pleasant sensations, unpleasant sensations, And there may be just areas of the body where there isn't much happening at all just now. Just into the space of this practice, I want to just drop a question. And the question is something like this. If you think about the role of contemplative practice, of mindfulness, whatever word works for you, through you and your work, what are your hopes for the next year, 5 years, 10 years? How do you hope that through your work in the area of contemplative practice, contemplative science, mindfulness, mindfulness-based programs, whatever words work for you, what are your hopes of how you might affect your own life, the lives of those around you, and the wider world in the next year, few years, and indeed beyond? Great, thank you. So I'm going to be speaking to some slides, so just give me a second while I share my screen so that I can do that. And hopefully you can see a title slide just now. Great. And what I'm going to be doing in the next little while is talking you through the work, particularly around mindfulness-based cognitive therapy, and perhaps also where the science and the practice of mindfulness-based cognitive therapy is pointing to going forwards. And I am actually, just give me a second because I need to open up a different slide deck. I've got the handouts version rather than the actual presentation version. So give me 1 second. Here we go. So this slide just here communicates something about a tipping point that we might conceive that we're at in the world just now. So what you see there is an ice structure, some people underneath asking, what's a tipping point? And the sun, the light of the sun melting that, that large ice-shaped object. And what do we think of when we think of a tipping point? And I guess this series of talks has been pointing to this. People will, I think, quite quickly jump to say climate change and the way in which the world's climate is changing in a way that could have catastrophic consequences in the next 50, 100, 150 years. Others might talk about artificial intelligence and the way in which developments in artificial intelligence are going to lead to unprecedented changes in the world. Others might say the profile of mental health and well-being in the world is changing. And that's the kind of tipping point that we're talking about, rates of mental health problems in young people, for example. If you stop and reflect on the last 100 years of human history, we've seen the most extraordinary changes in the history of Homo sapiens over 2,500 years. We have seen life expectancy go from being typically across the world under the age of 50 to, in places like Japan, being in the 80s and 90s, and across much of the world, including low and middle income countries, being well over 70 years of age. That's extraordinary progress. More and more of the world's population, to the tune of hundreds of thousands every month, are moving into greater economic prosperity around the world every year, year on year. Health status, education, access to technology, all of these things are changing at an unprecedented rate. And the basic thesis, the basic essential thesis, and it's going to be a lot more granular than this, but the basic essential thesis of what I'm going to be arguing is that these tipping point issues, climate change, AI, mental health, and these opportunities have all originated in significant part in the human mind and the human heart. And their solutions are also going to be found in the human mind and the human heart. And I would like to also propose to you that there is something of a vacuum of imagination just now in the world about how we might respond to some of these challenges. And I've just started reading this book, which I heartily recommend to you, by William MacAskill, who's a philosopher whose work in his career so far has been hugely influential. And in this latest book, what he is arguing essentially is an argument which I'd like to use to frame everything I'm about to say, which is, rather than a sort of catastrophic framing of where we are in the arc of human history, he argues that we are in a space where there is so much change, and so much change that we can potentially work with. Understandings about human health, understandings about psychology, malleability and how information and technology and working practices are working, that this is an incredible opportunity, he argues, for us to shape the trajectory of the next 50, 100 years. And then he sets out in some detail his own ideas about what that might look like. But the essential thesis is a way of framing what I want to argue, which is that a well-trained mind is what's going to be needed for us to be able to seize some of these opportunities. So what I want to do is I want to talk about the work we've done around depression and the way in which MBCT, mindfulness-based cognitive therapy, has played a part in that in the last 25 or so years. And I want to talk a little bit about where the work is going, and then I want to set out something of a vision for where we might go going forwards, framed in terms of that sense of a tipping point and that sense of a window of opportunity. So I'm going to start with the work we have done and the work around depression. Why is depression such an important and interesting challenge? And in some ways, why is it also potentially an exemplar for how we might tackle some of these other issues going forwards? Well, the World Health Organization has done really important epidemiological work over the years, and they estimate that somewhere between 250 and 300 million people in the world just now will be suffering from depression. If the world's population is about 7 billion or 7 billion plus just now, if you look at common mental health problems, that means about 1 billion of the people in the world today will suffer from mental health problems at some point in their life. 1 billion people. If you then look at where the majority of the world's population are living, about 1/3 of the world's population are living, China and India, the vast majority of people in those countries don't seek treatment at all. They suffer from these conditions without ever seeking treatment. And where they do seek treatment, various surveys report that in developed world countries, only about 1 in 5 people will experience optimal, good enough treatment. And in low and middle income countries, that's 1 in 27. Imagine if I had read out similar figures like that for cancer, or for heart disease, or for waterborne diseases. People would be mortified, but that's where we are for mental health just now, and for depression specifically. And so what I'd like to argue and set out is this vision, this idea that we know quite a lot about depression, and we have developed a range of treatments and approaches to depression that mean that a world without the devastating effects of depression is, I think, a realistic vision, is a vision that we could potentially aspire to. And in the same way that we might argue that education, gender equality are fundamental human rights, there is an argument in a recent Lancet Global Commission, first author, a large set of fantastic authors, Vikram Patel, where it's argued that mental health should similarly be regarded as a fundamental human right. Imagine that every child, every person, whether they're man, woman, high caste, low caste, every part of the world has a right to enjoy not just health, but mental health. And that we need to think about mental health in 2 ways, which are at some level self-evident, but at another level aren't, if you look at the way in which we're currently organizing our research and organizing our services. The first is that mental health is not an individual concern, or not solely an individual concern. It isn't that one person is prone to and suffers from schizophrenia and others don't. Yes, there are individual factors at the level of biology and psychology that make up an individual's vulnerability and experience of mental health. But mental health can also be thought of as a social phenomenon. How mentally healthy is a family? And indeed, when I used to work at the World Health Organization, I would spend time in places like India and Thailand and be asking about what makes for quality of life. And people would say, well, the family as a unit, and the mental health of the family is what's important, not necessarily the individual. And one could make the same argument at another level up, the level of a school or a workplace. Is this a mentally healthy school or workplace? And one could then make the argument up at another level, the level of a community, or indeed even a nation. This is something about the values around mental health, if you like. And then I think the next thing I would like to argue is that we need to think about mental health in a dimensional way. It's not that there are 1 in 5 people who will suffer from mental health. Actually, mental health is a spectrum from those who are currently, and this is a time shot, right? Currently unwell, to those who have got low-grade mental health issues, maybe issues around self-confidence, issues around sleep, issues around eating. One could say perhaps are languishing, through to the majority of people who are well, through to flourishing. And of course, it's more complicated than that, because you could be flourishing in one area and languishing in another. So mental health is a fundamental human right. It has individual and community and wider contexts, and it is dimensional. What are the implications of that? Well, one of the implications is you are never going to address that mental health burden or depression burden I talked about at the beginning through individual therapy or indeed through pharmacotherapy. You can't medicate a whole population. what you need to start thinking about if you're serious about this, everything that I've said so far, is you need to move from treatment. I'm not saying treatment is not necessary. I mean, people who are currently depressed, who are suicidal, who have all sorts of mental health problems need treatment. But if you're serious about mental health, you need to start to move to thinking about prevention. And that means taking folks not just who are unwell to the wellness range, but people who are languishing into the well range, because that we know is one of the best predictors of long-term mental health problems. And you need to think about the life course. This is a pretty typical life course for depression. So what you see on the left to right axis is the life course from birth through to old age and death. And what you see on the up and down axis at the bottom of the scale is frank depression. At the top is wellness and indeed flourishing. Somebody who is prone to depression will likely have their first experience of depression in late adolescence, early adulthood. And some 50% of people who have a first episode of depression will have a second. And if people have a second, you are looking more than likely at a relapsing and recurrent condition. Someone's life looks like that. They're moving in and out of languishing, in and out of depressive episodes, and never fully moving into the wellness and the flourishing range as a sort of typical or modal approach. And what mindfulness-based cognitive therapy started from, the premise it started from, was, can we work with folks who are at very high risk for having this lifelong course of depression and help them learn skills to stay well in the long term? Can we essentially change the trajectory of their life so that they remain well, they enjoy freedom from depression, but actually more than that, wellness and indeed potentially even flourishing? And I think this is an incredible success story actually in the field of psychological science, in which we have done a program of work where we have developed proof of concept of this approach called mindfulness-based cognitive therapy to prevent depressive relapse. We've done preliminary research. We've asked, is it effective? And we have made sure that that is scalable into actual healthcare services so that people can access this approach. And the slides that I'm going to be talking through now describe, in some cases, years and years of work in one or two slides. Every slide has got a website address where these scientific studies can be downloaded if you want to read them for yourself. So what I'm going to be doing is summarizing them, often in a sentence or two, in the interests of telling the narrative story that I want to tell without getting mired into the details of each of these studies. Hopefully I'll represent them all well and not misrepresent the sort of fundamental milestones in the scientific story, so to speak. So the first question, I guess, then, is if this intervention, mindfulness-based cognitive therapy, a group-based intervention to prevent depressive relapse, to help people stay well in the long term, does it work? Is it effective? And this individual patient data meta-analysis is of 9 randomized controlled trials, represents over a decade of work, more than 1,200 patients, 9 studies, and it very clearly demonstrates that mindfulness-based cognitive therapy, compared to other conditions unspecified in this particular analysis, prevents depression better than the control conditions. It works. It's an effective approach to preventing depression. It's incredibly gratifying and pretty consistent finding. The next question then is, what is, I've already said that in places like China and India, the modal way of responding to depression is nothing, but in other countries where treatment is recommended, it would normally be antidepressant medication. So the next question is, can learning these mindfulness-based skills, these life skills, be an alternative to long-term antidepressant treatment? So this was a study that we published in The Lancet in 2016, which compared a group of 424 people who learned mindfulness-based cognitive therapy and came off their antidepressants with a group who stayed on their antidepressants over the 2 years of follow-up. Can mindfulness-based cognitive therapy essentially provide the hundreds of millions of people around the world on continuation long-term antidepressants with a way to stay well in the long term? And there was the suggestion in this study that the answer is yes, but it wasn't conclusive. So again, a meta-analysis of 4 studies, 3 MBCT studies and 1 cognitive behavioral study, combined the data from all of these studies. And again, it very clearly indicates that for those people who choose to come off their antidepressants, having learned skills in mindfulness-based cognitive therapy or cognitive behavioral therapy in one of these studies, that's the Bochting study at the top, could stay well in the long term. It's incredibly exciting, incredibly interesting. If you stop and think about that for a minute, it actually makes a lot of sense, because what you're doing with mindfulness approaches is teaching people to better understand their mind, to see their own individualized moments of depressive relapse and learn ways of responding which are peculiar to them. What you're doing with antidepressants is giving a globalized drug that affects the entire nervous system and the reuptake of serotonin in ways that we don't fully understand. Yes, it's effective, but what we've got with these psychological approaches, when delivered well, when learned well, is incredibly bespoke approaches. And then, just very briefly, we've asked, is it cost effective? And the answer is yes. You might say, well, antidepressants are pretty cheap, particularly when they're off patent, but actually we've demonstrated in a series of studies that these psychological approaches in the medium and long term can be as, if not more, cost effective than long-term maintenance antidepressants. With all of the work we do, we have to also take care to make sure that we're not doing any harm. And probably about 10 years ago, there was quite a lot of research and media concern about meditation being potentially harmful. So Ruth Baer and myself and others have spent quite a lot of time doing some conceptual and empirical work around this. And Ruth has made the following points, which I think are really powerful points. Consider physical exercise. Consider any medical treatment. In fact, consider anything that is potent. Anything that is potent involves a risk, cost, benefit analysis, because the potency by its very nature will potentially have some effects in undesired and unexpected ways. So in the States every year, if you think about physical exercise, there's no doubt that physical exercise is good for cardiovascular health and for health generally. But every year when the snow comes down in the States and people go out and they start clearing their driveways with a shovel, which is incredibly high intensity cardiovascular exercise, a few people will die. But people don't say that physical exercise is deadly, it should be avoided at all costs. The very fact that we are putting stress and pressure on the heart is what leads to these effects. So what Ruth has argued, I think really powerfully, is that any potent intervention potentially could have some adverse effects or harms, but those need to be mitigated by high quality training, consideration of those risks. You wouldn't ask somebody with at risk for heart disease to go out and shovel their driveway. You'd ask them to not do that and to go on a graduated exercise program. And I think the same is true in relation to mindfulness-based programs. Again, you can read those papers in your own time if you choose to. And then the final thing I wanted to say on this sort of arc before I move into the next phase of what I want to talk about is all of this work only has value if we can get it into practice. And so what we have done is quite a lot of work to understand how you can create the changes in systems so that mindfulness-based cognitive therapy could potentially become accessible throughout healthcare systems. This is a piece of work that we did over 3 years in which we looked at the barriers and the facilitators to implementation. And I think in the UK now, mindfulness-based cognitive therapy for depression is recommended by the National Clinical Guidelines and is available in the National Health Service, I would say in excess of 60 or 70% of the National Health Service. If you go and see your general practitioner, this is a treatment that should be accessible to you. It's in the clinical guidelines, I know, also in the Netherlands, in Canada, in North America, in Japan, in New Zealand, Australia, and many other countries around the world. So this is an intervention that I think has gone round that whole translational pathway. And I think that is work that we can be really pleased about and proud about. There is work now to think about making that more accessible, for example, through online interventions. This is the work of Sona Demidian and Zindel Siegel. And there is also work to make sure that the work we do is held within a broader ethical framework, and that we have trainings and training pathways that are widely respected and are seen to be best practice, and that we also work at the policy level to make sure that the work that we do is integrated into wider policy. So I'll just sort of do a sort of interim summary and say that whilst mindfulness-based cognitive therapy for depression is not a panacea, the work that we've done suggests that for those with a substantial history of depression, this is a really useful, effective approach to learning skills to stay well in the long term. What we're doing now is taking this public health argument and broadening it out further. Can prevention be moved upstream? So we're starting to do some work led by Tamsin Ford and others, where we're looking at adolescents who are already in services, who are showing that prodrome or that profile, if you like, that places them at high risk for depression. This is very early proof of concept work. And what we've done is we've taught them an adapted MBCT program and got their parents in parallel, so the parents also learn mindfulness skills. And the young people and their parents then go home. And this intervention developed at King's in London, at Exeter, in the southwest of England, has shown really promising proof of concept. Now, you might say, Willem, you're presenting this in quite a rosy way. And when we published some of that effectiveness work, Richie Davidson sort of threw down the gauntlet a little bit in this editorial, in the same issue. He said, this is all well and good, but actually your outcomes are good but not great. And if you're going to move the dial towards better outcomes, you're going to have to get better at how you measure these key constructs, your outcomes, your mechanisms, mindfulness itself. You're going to have to understand how these interventions work. And if you can do that, you can really hone in on the things that make MBCT effective and make it yet more effective. It was a really good challenge, and a challenge that we've spent the last 8 years responding to. I don't know if this is your experience, but the experience I have is that the word mindfulness itself has, in the words of a New York Times editorial, become rather muddied. And I think we have an obligation, in response to Richie Davidson's challenge in a way, to become much better at communicating what we mean by just the very word mindfulness. And I'd like to just offer this image and these 4 words, that if we are to bring mindfulness into the common parlance in a way that honors its integrity, honors its richness, so that it sits alongside words, I'd like to say, like wisdom, like discernment, like beauty, like art, then what I'd like to offer is the metaphor of a diamond that has tremendous strength and that can be seen from all of these different facets. And I think these 4 different facets are tremendously helpful as a way of thinking about mindfulness. That mindfulness has an intention. In the case of recurrent depression, is to help people recover from depression. It has an ethical framework about what it is that we are hoping that the learning of mindfulness, the embodiment of mindfulness, will help move the dial for an individual or a larger group of people. So it has an intention. It has attention, the training of attention. It has, that's not a cold glare of attention. It is imbued with attitudes of curiosity, of kindness, of care, of courage. One could say that it's imbued with a way in which the mind is befriended, if you like. And it has attached to it action. The action could be internal, or the action could be external. And when we think about mindfulness in this way, I think it becomes less muddied. It's nonetheless a complex construct, but is a less muddied construct. I think the other thing we need to respond to Richie Davidson's challenge is a map. We need theory. And I think one of the reasons that MBCT for depression has been so effective with such a difficult condition is that Zindel Siegel, Mark Williams, and John Teasdale articulated very carefully a psychological account of recurrent depression, and then how MBCT might address those mechanisms. Anybody who has suffered from depression or knows somebody who suffers from depression will empathize with this image. The cardinal symptom of depression is waking up early or in the middle of the night. Here is Matthew Johnston, who wrote this book, I Had a Black Dog, waking at 3:20 in the morning. And the black dog is sitting on him. He's been visited by the black dog. And what you'll see on the wall behind him is the flood of thoughts that at the moment of depressive relapse can catch somebody who's vulnerable to recurrent depression. Life is too hard. I'm no good. I'm no good. Why can't I? I feel so bad. I'm going to feel terrible in the morning. This flurry of negative thinking is what MBCT is addressing. It is helping people to recognize the black dog. You can see in the second image, the black dog is still there. Step back from, decenter, if you like, from the black dog, and respond in ways that are more healthy, wise, discerning, so that that relationship with the black dog is changed. These 3 people on this slide, these papers, all describe studies in which we can see that MBCT does indeed create these changes, and that these changes are associated with improved outcomes. This is a paper that's just been published in Biological Psychiatry from Anne-Mai van der Velden, a PhD student in my group here in Oxford and in Aarhus, in which she was able to demonstrate that at the point that people start having that depressive rumination, you see changes in the salience network, one of the networks in the brain that is about when attention is engaged or is sucked into depressive rumination. When people learn MBCT, they're able to switch out of that rumination. They're able to switch their networks and recognize what is salient, what is relevant, what is not relevant. And so we're seeing a really nice triangulation between a self-report of decentering and changes in the salience network that are associated with depressive relapse. And then finally, in relation to how can we do better with depression, how can we do better with MBCT for depression, there are now a number of really interesting studies, which I think could be game changers, not just for depression, but actually I think more broadly. A patient once said to me, Willem, the CBT, the cognitive behavioral therapy that we've been doing together has been really helpful at moving the dial from me being in a really dark place, a really depressed place, to being not depressed. But I feel like I don't have the skills to know how to move the dial into a place where I feel I can be in the light and know how to enjoy that light without having, for example, dampening appraisals. I don't deserve this. This is not familiar to me. I don't even know how to navigate this. And what we've seen in a number of MBCT studies, at least 2 that I'm aware of now, and 2 cognitive behavioral therapy studies, is that if people are also learning how to appreciate the positive, how to savor the lovely, how to connect and feel loved, how to essentially activate the positive valence system, you see further improvements in recovery from depression. So we're not just moving the dial from depression to 0, we're helping people move from depression to 0 and into the well and the flourishing range. And I think that together is some of the response to that gauntlet that Richie Davidson threw down in his editorial. If we can make these changes and sharpen what we do, we can get better recovery rates. So more recently, we have taken the Jeffrey Rose argument and the prevention argument and gone one step further. We have said, well, when do mental health problems first arise? And I don't know if this is a kind of an artifact of measurement or whether there's a reality, but there is almost certainly a movement earlier in the life course to when mental health problems first arise. Some 75% of all mental health problems will have arisen by the age of 24, 50% by the age of 18. So what's that telling us? It's telling us that if somebody is going to suffer from mental health problems, they're likely to happen in late adolescence and early early adulthood. So for depression, for example, you see the the blue line here. The peak is at about 19 years, but it's starting in mid and early adolescence. Well, that tells you that if you really are serious about prevention, you want to go to primary prevention. You want to start working with kids before mental health problems first arise. It's kind of a logical argument, right? Let's work with kids before mental health problems first arise. And that has been what we spent the last few years potentially working on. Can we take children in that developmental window, and can we work with all children to potentially move this bell curve towards greater well-being and flourishing by teaching skills that are applicable to the whole population, not just the kind of ruminative skills that drive depressive relapse in secondary prevention and in treatment, but by teaching skills that all children could potentially use. So we've spent the last 8 years working on this project called the Myriad Project. The website link on here takes you to the description of the project and all of the papers that have been open access published today. But this was a program that explored whether schools-based mindfulness training could improve the mental health of young children in that developmental window before mental health problems first arose. Why schools-based? Well, this is where young people are spending the majority of their lives, and it's a place that becomes increasingly important to them as their peer group and their sort of more external facing lives take shape. And our question was, can school-based mindfulness training improve resilience, mental health, and well-being in early adolescence? Can a program based on MBSR, based on MBCT, based on psychoeducational principles, that was developed by school teachers in a school context using a pedagogy that is mainstream educational, teach young people these skills and enable them to be more resilient. We recruited 28,000 children, about 100 schools, more than 650 teachers, and the results were published just last month in one of the BMJ journals as a special issue. So we published the data on children, we published the data on teachers and school climate, and we published an updated systematic review of the literature. What did we find? Well, the first thing we found was that we were on the money in terms of what we suspected was happening around the mental health of young people in this nationally representative sample of 26,000 children. As many as 1 in 3 children reported significant depressive symptoms and social, emotional, behavioral problems. So if you're sitting as a teacher in a classroom of 30 children, 10 of those children will report significant depressive symptoms and or social, emotional, behavioral problems. And if you plot it in this kind of graph of distribution, 17% are reporting frank mental health difficulties, 12% are languishing, 16% are flourishing, and the remaining are enjoying normal well-being. I'll allow you to form your own judgment about whether that is an acceptable level of mental health problems in the young people of a nation. So, was the intervention effective? It's a large study, it was a cluster randomized controlled study, and well-funded. We were able to make sure that many of the biases that you see in a trial were eliminated. We were adequately powered. Our data integrity was very high. We lost almost no people at the final follow-up. We can have high confidence in the findings that the question we set out to ask with the intervention that we delivered, we could know the answer. So was the mindfulness training effective for teens aged 11 to 14? The answer was no, it wasn't. We saw absolutely no signal of any change on any of the key mental health or well-being outcomes for children. We had some secondary outcomes, young people's mindfulness skills, attention deficit problems, and there was a slight signal that the children in the mindfulness condition did actually slightly worse than the control condition. That's I think the third mindfulness study to show that, and there have been 2 CBT studies that have shown that, and 1 peer mentoring program that has shown something similar, and one mental health literacy program in schools, where the intervention has had some slight signal of an iatrogenic effect. What about the teachers and the school climate? Well, here, really interestingly, we saw the school-based mindfulness training was helpful for the teachers. The teachers themselves learned mindfulness, went through a mindfulness program, and rates of burnout in the teachers went down. This is a not insignificant finding given how rates of teacher mental health problems and attrition in the teaching profession. And we also saw changes in the school climate. So I was presenting this data last week, and John Kabat-Zinn, who I've been talking to about the findings all the way through the last year or so, was there last week. And he said, you know, these results really are a wake-up call. They're a wake-up call to help us to think about how, what can we learn and how do we move forwards. And I think there are at least 3 big messages. 1, if we're serious about young people's mental health, we've got to give up on the idea of there being a magic bullet. There's going to be one thing that's going to make a difference. We need to think about the wider context. Our data points to deprivation and social inequality is a major driver of mental health in children. We need to think about the meso context. Our data strongly points to an association between the overriding climate of a school and the mental health of the children in that school. And at an individual level, there are a lot of individual differences in children and mental health that need to be taken into account. For example, neurodiversity is an example of something that's associated with mental health and needs taking into account. To make this a bit more concrete, there is a school that Michelle Obama visited a few times when she was in the White House as Obama's as the First Lady, and this is a school that was turned around, absolutely turned around from a struggling school into a highly successful school in a very mixed part of London that was able to, all-girls school, that was able to honor the diversity in that school and give the girls in that school a sense of their sovereignty, a sense of their possibility, a sense of their different styles of learning, and actually a real success story of how at this sort of meso and individual level, an intervention can make a big difference. I just want to point you towards the school uniforms the children are wearing. One of the things they did in this school was they gave the children the job of redesigning the school uniforms so that they could be both a unified uniform, but one that could be worn by people who are wearing a hijab and from people from different backgrounds, so that they would have some way of expressing their own cultural identity and individuality within the context of the school. A really interesting intervention. The second thing we learned is that anything you do with children and young people has to be co-designed. By definition, an adolescent asked to do something by an adult that the adult thinks is a good idea is likely to backfire. And so I think there's a real imperative that anything we do going forwards has to be co-designed. And the final thing we found, which we were perhaps surprised but shouldn't have been surprised to find, is when kids were anonymously asked how much they engage with the mindfulness practice and how much they use the mindfulness practice, the vast majority of young people said barely at all. So here was an intervention which, when you ask them not anonymously, many of them will say was helpful, or teachers will describe as helpful, but in an anonymous format, they didn't practice. So there's no such thing as a free lunch in behavior change. If you want behavior change, you have to get people to change their behavior. And in this case, practice the mindfulness skills. And this particular curriculum taught in this particular context wasn't able to do that. So I'm just looking at this the time, and I think what I'm going to do is I'm going to skip forwards to where we're going in the work going forwards, and recognizing that mindfulness-based programs in adults, I'm not talking about the schools-based work now, are teaching skills. People are describing learning skills that go beyond depression and go into other areas of mental health and well-being. So can we extend our vision to people enjoying mental health and well-being across the lifespan? Can we have this idea of mental health being something that is potentially available for all, and with mindfulness-based programs playing a part in that? Well, I think for that we need a map, a theory, which I think we have in terms of some ideas about universal aspects of what supports mental health and well-being. I think we know quite a lot about that. It's just that it's not applied into everyday life. And then what we need to do is we need to take our mindfulness-based programs and take their essence and retain those, but then adapt them for particular cultures, people with different values and communication styles, and whatever our intention is in these different settings, be that in a workplace or be that in a school or whatever. And I'm going to just skip over this bit because I'm mindful of the time and I want to make sure that we have some time for questions at the end. So what is happening in the kind of evolution of mindfulness-based programs is we've gone from John Kabat-Zinn's initial work on mindfulness-based stress reduction in hospital settings, being much more broadly applied, and Mark Williamson's, Zindel Siegel and John Teasdale's work on recurrent depression, moving into different clinical presentations, cancer, health, anxiety, suicidality, into the mainstream, into the whole population, with this idea that we're trying to reduce distress and suffering and increase flourishing. And for that to be a successful project, we need to make what we do accessible. So Mark and Danny wrote this book, which I think is now touching on to 2 million sales and 36 language translations. That is a way of potentially making mindfulness more accessible. But when you do that, there is a trade-off between accessibility and engagement, and a trade-off that that is one that you can think about in this way. So what you can see in this slide here is a funnel, where on the left of the funnel, you'll see the whole population. And on the right of the funnel, you see a group of people who have taken mindfulness-based programs and taken them deeper and further. So how, with really broad reach, in a highly accessible way, can we make mindfulness as accessible as possible? So Mark and Danny's book is an example of that. But what I'd like to propose is an even better example of that, is potentially schools or workplaces that have a climate or a culture that supports mental health and well-being, that one could say is mindful, that the mindfulness is learned in an indirect way. As you then move further into the funnel, people maybe learn these skills themselves through apps or through reading books. And then what you need to do is to provide a way of people to have a face-to-face program where they can have more support from a teacher. And for that, we've developed curricula, face-to-face curricula like MBCT for Life. And just recently, for graduates of those programs, we have developed a curriculum which we're calling Mindfulness Taking It Further. And I want to show you the data that's just about to be submitted for publication, or just has been submitted for publication actually, in which you see the Jeffrey Rose curves. And what you see on the left is the, it's a randomized controlled trial. And what you see on the left is the control group before and after at the 2 time points. And what you see on the right is the well-being distribution for those who went through this Taking It Further curriculum. And the gray on the right is the flourishing range. So what we're doing is we're taking people who are well and we're actually moving them into the flourishing range. And that is this sense that we potentially could have a public health intervention, a bit like with heart disease, where we're working on heart diet and exercise, where we are moving heart health for the population as a whole. We're doing the same with well-being for the population as a whole. How can we maximize reach, engagement, and effectiveness, and minimize harm across this whole population? So just want to finish with something of a vision with 3 horizons. Can we envisage a world without the devastating effects of depression, where people enjoy mental health and well-being across the lifespan, but actually these trainings resource them to meet some of the challenges of the next 50 years? This is where we are at the moment. This is what the population looks like at the moment, and this is actually what national data on well-being suggests well-being looks like across the life course in countries around the world. What I'd like to suggest to you is that is not where we want to be. I don't think it's acceptable to think that 1/3 of children between 11 and 14 should describe significant levels of depressive symptoms. We need to move beyond that. And here are some of the things that we are beginning to see happening in terms of emerging innovations. things that are having this population context. So Vikram Patel, for example, talked in his United Nations Sustainable Development Goals about the need to focus on these macro wider levels. Having high quality education available to a whole population is one of the best mental health interventions that one can deliver at this macro level. What about at the meso level? I just want to show you this. This is kind of cool. I don't know if anybody here has ever been there, but this is Gorky Park in Moscow. This is a design concept. It's a set of swings designed for teenagers. Massive, great big swings with a light complex, and the lighting system and the design is about encouraging teenagers to hang out here and to hang out together. And the lighting system is designed to create it so that the young people will congregate together, depending on how many people are there. It's the idea that one can design and use design to support mental health. The school I talked about earlier, I think, is a really good example of a school designed with meso and individual level factors to potentially support mental health and well-being. And we've just secured funding from the National Institutes of Health Research here in the UK to develop a new intervention, a new framework to think about nature, leisure, gardens, libraries, museums as potentially a way to support mental health and well-being, particularly in young people. So I'd like to just leave you with this radical possibility that these macro, meso, individual level interventions could potentially make this aspiration of mental health as a fundamental human right an actual possibility, in the same way that things that we thought about 50 years ago may not have seemed possible and have come to fruition. Just want to end by acknowledging that everything I've talked about in my talk so far is very much the work of a collaboration and a team of people that I've been lucky to work with. And I also know that some of the papers and the resources that people sometimes ask me about, made those available on the URL link just here. So thank you very much for your attention, and hopefully we've got some time for some questions.
Thank you, Willem. Thank you so much for your talk. It's very inspiring. All aspects were fascinating to hear about, and I'm really looking forward to the questions from our audience, from our friends here. And while waiting, I may pose one just to start the discussion. It was astonishing to learn about the lack of significant influence of mindfulness practice in the younger generations, children especially. And I was wondering whether that relates to their age, their generation in general, or whether that relates to the contemporary situation that they find themselves in. Were there any studies in the last, let's say, 1 or 2 decades when you colleagues would have measured same interventions with children at that time, 10 or 20 years ago, compared to today? And if yes, would there be any significant change, how these practices affected children 10 or 20 years ago? And if yes, what would that tell about the current situation that these children find themselves in and how they interpret their reality, their environment, and their surroundings? If not, then it may still stay as a question.
What a great question. And I think this is what John Kabat-Zinn meant by it's a wake-up call, because it forces us to ask that question, right? And what you did there was you moved between generations. Is it something about this generation versus other generations? You moved to the population. Was it something about children of this age? One could also say, is it something about the intervention? Was the intervention not quite right, or was it delivered by the wrong people? I don't know the answer to your question, but I think the answer will come by attention to the macro, the meso, and the individual level variables. So we did, as part of the special series, look at what factors were associated with outcomes. And what we were trying to do was get to a point where we could say, if only it was done in this way, it would have worked. But there wasn't enough signal for us to get to that endpoint. But what we did see was some hints. So here were the hints. Older kids did better than younger kids. You think about it in Piagetian terms, they've got that kind of meta-awareness that maybe mindfulness requires. So the 14, 15, 16-year-olds did benefit, but the younger ones didn't. The kids with mental health problems at the beginning of the study got worse, and the kids without mental health problems benefited a little bit. So I don't know, but my hunch is what we were doing with the kids with mental health problems was we were giving them a bit more awareness of their mental health problems and tools not quite strong enough to work with them. And we also saw that in areas that were really more deprived, the intervention did better than areas that were less deprived. And I think maybe there was less on offer in those schools, in those places. So the kids, so I think there were some hints. We also found that the kids who practiced benefited, but very few kids practiced. And we also found that getting teachers to be really competent in teaching this curriculum was really hard work. You know, we only got probably about 50, 60% of the teachers up to a level of competency that we thought was barely good enough. So your question's a great one, but in a way, what I would like to do is not to simplify it and say we have a long way to go to understand the macro, the meso, and the individual, and rather than give up, let's wake up and say, I think without a shadow of doubt, I can say the following things. If we reduce inequality and poverty, we'll improve young people's mental health. If we increase a climate of schools where kids feel safe and there's a sense of mutual respect, we'll improve mental health. If we create schools where there is not just one size fits all, but the kids who are neurodiverse, the kids who are sporty, the kids who are arty are given different opportunities, will improve mental health. Those, are, I think, are some clear signals from the science. But it's a great question. And I think we shouldn't give up on this work. I think we should see this as an incremental movement moving forwards.
Thanks so much. Thanks, Willem. I can see three friends raising hands. First one is Annie Block. Annie, please ask your question, and then we will continue with the other two.
I question the idea that there is such a thing as mental health. There's just health. This is a division. We know things are psychosomatics, and you say, you know, mental health is psychological, social, environmental, but it's also biological. Mm-hmm. And if you think that biological is just antidepressants, that's just a very tiny aspect of the biology of health. Right now, there's so many other approaches, and I think this is very important. And for instance, I'm thinking of what's something very famous, the Adverse Childhood Experience Study, which is a long, lifelong study where you see that there are a lot of physical problems coming from this young bad experiences at that young age. So I call for something much wider. If it's like having a hammer, if you have a hammer, you find everything is nails, and there's something about that. Of course, it's your track and you have to follow it. But I feel, you know, for instance, I wonder teaching learning skills, it could also be seen as a form of conditioning. And I can see children resisting the conditioning. So that's all I wanted to say. I can give you some information about this biology of trauma, a few references. And I see the same problem in spirituality, some sort of form of materialist focus on meditation, not having a wider picture. That's it.
Thank you. And I actually agree with everything you said. I don't disagree with anything you said. I think there is, when I talk about the individual, the meso and the macro, that could equally be biological. So when I talk about individual, I don't talk about individual psychology. I talk about the individual organism, which is biological, psychological.
Right.
And of course, as you say, Annie, you know, the biological can also be meso. It can be about diet. It can be about levels of stress that we're exposed to. It can be about the technology that we have in our lives. So I agree with everything you've said. So the story I was telling was just the story with a particular narrative stream, but nothing you've said I disagree with.
Yeah.
Thank you, Annie. And yes, hopefully we will also hear about those other dimensions in other occasions from those who are studying them. Sophie McIntosh.
Hi, Willem. As you know, I have 2 caps. I'm a teacher in a school and I also teach mindfulness. So what's interesting with what you said about the myriad and the, you know, sort of the success at the teacher's level, which is understandable, the less successful maybe sort of results at the teenagers or the, so I'm saying is my idea is to bring mindfulness to my school, to be there, and to, first of all, as you said, is refining the word mindfulness to my headmaster and to the senior teachers. But my question would be, from the myriad's results, would we be better off starting like a pyramid system with the teacher, training, offering mindfulness to the teachers so they have a better, well, understanding first, but also no or less burnout, feeling better and happier, so that it trickles down. If you have a stronger staff in a mental health that is positive, that will trickle into the children before you're offering them then a mindfulness approach or mindfulness strategies. And obviously the other question I have is the practice, because to me it's like, for the kids it would be like homework, and homework automatically they just kind of going to go, no, if I don't have to, why should I? And how do you overcome this? And so is there any sort of further studies from the Myriad Project to address these issues? Thank you.
Thank you, Sophie. And again, a great comment and a great question. And I think, you know, what I'm about to say is, of course, speculation. And I don't want to be polarized or simplistic, because I think, you know, there are children who will say learning mindfulness is tremendously helpful to them and has been life-changing. There's no doubt about it. Just because in an adequately powered at a population level study it's not effective doesn't mean it's not effective for all children. But I've spent, you know, a lot of time thinking about this data and these findings, and if I'm really honest, I think, I don't know about other countries, but I think the UK needs to rethink its educational system in terms of the values, and a bit like Annie's point earlier, a culture of constantly striving, of treating all children as if they're the same, a relentless focus on assessment. This is like a form of chronic stress, and you could even go further to use Annie's language and say chronic trauma. It's not good for the body, it's not good for the mind. And you can teach teachers to your heart's content, but if they're going in and their days are back-to-back lessons with paperwork and photocopiers that don't work and all of these kinds of things, you could almost make teachers more aware of how difficult their jobs is. So I just wonder, so maybe there's a level even above that. There are some people beginning to work in this area, working with the senior leadership team initially, and the governors around the school and so on, who are the context for the school. I'm not saying mindfulness with children can't be effective, but if you are working with that discrepancy of a striving-driven, assessment-driven culture, and you're trying to teach mindfulness within that, I think that's quite tricky. So I would start with a long view, first of all, that nothing's going to happen in a term or a year. It's likely to be 5 years. and with a top-down and a bottom-up approach, and a lot of patience, and an acknowledgement that these, so I know the UK system really well. These UK educational systems are driving stress, and they are driving problems, I think, and that needs a radical rethink. My colleague Sarah Jane Blakemore has done a lot of work on the sort of development of the adolescent brain. And in the UK, we have really important exams called GCSEs at age 15, 16. She said, if anybody who understands the development of the adolescent brain would say that is a terrible time to be doing a national test, because it's a time that's in the midst of puberty for a lot of people. So some people's brains have gone through a lot of changes, some are pre that change, there's a lot of stress. It's not a good time to be doing a big national assessment from a sort of biological brain development point of view. So Sophie, that doesn't directly address your question. I think just having that sort of bigger picture about the factors that are impinging on a school, on the head teacher, on the senior leadership team, on the governors, on the parents, on the kids, and how you can bring some interventions into that space that could be effective. I think that's the skillful work. I'm sorry it's not a simple answer, but I don't think it's a simple question.
Thank you for the question as well as the answer, Willem. Karin Matko is the next one. Yes. Karin.
Hi, thanks for the wonderful talk again. And I was just thinking about like you probably know the Perry Preschool Project, which was like showing how helpful prevention is at a very young age. So like starting with 5, I think it's over 5. So maybe it's even better to start at this age. But the other question that I had was a bit, yeah, I don't know, blasphemical in a way, because you showed us a beautiful curve from languishing to flourishing, but it's a normal distribution. So my question is, isn't there such a thing as a normal distribution of mental health? And isn't it normal that people suffer and others flourish? So like, it's I don't know if it's like an utopian view to think that all people should be well. Although it's a good view, I think I would wish that too.
Great question, Karen. Great question. So it's why I placed it under the sort of values section, because I think it is about the values of society, right, and of a culture. Are we going to value well-being? Are we going to value flourishing, or are we going to value other things like economic growth, or do we see them as being so? I think it is about values. I think it is in part a philosophical question. But I think you might be slightly misrepresenting, and if you go with the point that was made earlier by Annie about the way you define health, of course we're going to have ill health. Of course we're going to die. But well-being, as I define it, and I see it defined by organizations like the World Health Organization, is about social connectedness. It's about living a life that's aligned with one's values. It's about a sense of taking a sense of value and meaning in one's life. And I think, yes, I would say those are values that we would aspire to. I would make then maybe a statistical stroke methodological point in response to what you say, which is, I think, a really interesting one that people are beginning to think about, which is I represented the Rose argument in a really simple way. Can we move the curve towards greater flourishing and well-being? There are other things you could do. You could reduce the standard deviation. So what you could do is, I mean, these are philosophical, political, social arguments, right? You could say another approach would be to move everybody more towards the middle. Hi, I don't know, Karen, who's just joined us. Should we just say hello? What's your daughter's name? Oh, I can't hear you because you're muted.
It's Sarah.
Hi, Sarah. Nice to see you. We could also say that actually what we want to do is we want to, by reducing inequality, we want to just narrow the curve. And there may be other interventions that actually change the shape of the intervention. So they do work with pulling more of the people who are unwell into the. So there are other approaches other than that very simplistic approach. But I think what I'm trying to do is to say, let's think about these things differently. I don't quite know what the answer is yet, but if you go with William McCaskill's argument, there is in many places, I think, a real failure of imagination. And I think what we need is imagination and people willing to carry through that imagination, so that people of Sarah's generation will walk into a world where some of those possibilities are being explored, rather than we are catastrophic about the direction of travel. I mean, I'll just give you an example. When I was Sarah's age, I would sit in the back of my parents' car and they would both be smoking and there were no seatbelts. And Sarah, I would bet your parents don't smoke in front of you and they make you put a seatbelt on when you get in the car. That is normal practice now. When I was your age, which was, 40 odd years ago, that was not normal. So I think around health, mental health, well-being, we can in 50 years imagine really very different practices. Again, if you were to walk in the supermarket with a child and you were to hit that child, in most cultures now, people would find that quite shocking. But people will say quite unpleasant things to their children in supermarkets and in public spaces, and people will walk by thinking that's relatively normal. That's a form of psychological insult or social insult that is still considered normal, which I think 50 years from now maybe shouldn't be considered normal. That's an example, I think. So again, a rather wide-ranging answer to your question. So I don't think there will be illness, there will be sadness, there will be death. It's not about eliminating those things, but I think it is a realistic and worthwhile aspiration that mental health should be something that we should all feel that we can enjoy in our society.
Thank you. We still have a few more minutes and maybe 2 more questions. And while waiting, I would ask another one, Willem. I was really shocked by the figures you mentioned, that 1 in 3 children reported significant depressive symptoms, 17% unwell, and 12% languishing. That's a huge amount. And it would be wonderful to see the vision that you presented come true by 2050. And even if all circumstances or all conditions were the same as we have them today, it would be an uphill battle, considering this large number of the younger population or younger generation. And I'm wondering whether you measured what the real reasons and causes are, what led these children to express this feeling of being unwell and or languishing. Do we know the reasons? Do we know the causes?
Yeah, we are.
And aren't we also seeing these circumstances deteriorating, like climate change, like lack of meaning? Do they feel something that we adults may not feel yet, that is waiting for us in the coming decades? So I'm just asking this question related to 2050 and the uphill battle that is awaiting us.
There's a really sobering statistic for those people on listening to this talk who have children, which is that apparently my parents' generation believed that their lives were better than their parents' generation. And they believed that my life was better than their life. But the parents in this generation are beginning to reverse that. They are beginning to worry that their children will have a worse life than they have. That's quite an interesting point in human history, right? Where you go through several generations where parents believe that they are leaving their world in a better shape for their children, to parents now wondering if their children are inheriting a worse world than the one that they lived in. I think that's really interesting. And of course, the answer to your question, incredibly complex. But what we did do is we asked the young people to design a study and the questions of what was important to shaping their mental health. We're just writing this up now. And then we went out and asked the next cohort of kids, so I think about 4,000 children, to what degree this was indeed shaping their mental health. And some of these things are not rocket science. They are really simple things. They're about connection. Having a friend you can talk to and having peers that you feel connected to, about not feeling completely stressed at work, at school rather, by exams, and having relentless demands placed on you. This is what the children said. Now, of course, and one of the things I think, again, I keep saying this, is we have to be really careful not to polarize and be oversimplistic. So a lot of adults will say, oh, it's social media. But actually, a lot of young people will say social media is their way of connecting with their friends. It's their, a lot of boys are connecting with their male friends and playing games, and that is their social life. It's not necessarily a bad thing. So I think I mention that only because I think it's too easy to simplify. And I think, again, Gabor, it's a great question. And I think we have to have, it's like John Kabat-Zinn, it's a wake-up call, right? What is going on? And how do we respond to it? So I'll give a very small example on social media, again, from the data from our work and the literature that I'm aware of it, is I don't think social media is a bad thing, but lack of sleep is really bad for your mental health. That's pretty consistent. If you don't sleep well, that's not good for your mental health. And a lot of young people report being tired at school most of the time. So I think one take-home message is social media is not a bad thing, but leaving your phone in your bedroom with notifications on all night is probably not good for your mental health. So it's a very concrete, small thing, right? But that's just threading together the data from our work and others' work as well. I do think you're right that young people are worried about climate change, and they're worried about things in a way that our generation perhaps weren't. And that, again, is about co-design with young people. What can we do about that? How can we work with that?
Thank you. That makes a lot of sense. And maybe just one final short question from Hotri Himasri Alapati. Are you here? Would you like to ask your question yourself? Or shall I read it out loud?
Hi, thank you so much for the talk. It was great to hear the findings. And as a teaching assistant myself, I'm trying to help some of the students learn mindfulness. And the students that I'm working with are around 10 years of age. And I think the findings that you have presented, I can see that to a certain extent. So my question would be, what would you say is the next question that we need to answer as a society in terms of the effect of mindfulness on adolescent mental health?
Can you just repeat the last part of your question? So what is the question that we as a society, I didn't catch the last part of what you said.
I was just wondering what would be the next step in answering the question of the effect of mindfulness in adolescent mental health.
The effect of mindfulness on adolescent mental health. What would be the next question we need to answer?
So, thank you for your question. And of course, the work you're doing is with children a little bit younger than the group we were looking at. So we were looking at 11 to 14-year-olds, and it sounds like you're working with 10-year-olds. And I think the issues in primary education are probably a little bit different. So just to say that. I wonder, having spent quite a lot of time thinking about this, whether social emotional learning programs that are universal, I offer to all children, might be most effective if they were indirect. What I mean by that is they work through the climate or the culture of the school. So rather than necessarily focusing on teaching the kids skills, can you somehow work it into the fabric of the school so that actually the school is run in a way that is mindful at every level, the way the corridors are and actually even further than that, potentially design. So the physical design of the school that is designed in a way that supports, places like Denmark have got some really innovative ways of designing communities that create a sense of space, create a sense of connection with nature at the same time as supporting community. So I know this is maybe slightly left field, and if what the work that you're doing is working as a teaching assistant with children, that's not quite what you're asking. But I go back to what I said before, which I think it's a both and. If you think about the way in which a mountain changes its shape over millennia, it's through every single raindrop will over time make these changes. And I think that's part of Will MacAskill's argument, and that's why I led the practice I led at the beginning in the way that I did. We all in small ways have the possibility to shape things in a positive direction as parents of children, as uncles, as aunts, as grandparents, as teaching assistants, or whatever. These are all collective endeavors, I think, towards this aspiration.
Thank you. And there is a bonus question actually in the chat from Amy, and I find that really interesting. And so Amy, maybe invite you to share that as the last question. Thanks.
Thank you, Willem. This was an absolutely terrifying and wonderful talk you gave us, and but I guess sort of hopeful in a way in the end. I know very, very little about the actual practice, in the room with MBCT, and I was really struck by this notion of, I think you said from MacAskill, a well-trained mind is needed to imagine the future, and that we are in a vacuum of imagination. So given my limits of understanding about what actually happens in a session of MBCT, I'm wondering if any part of the practice addresses the imagination, actually. You mentioned attention, you mentioned a few other things, but the space of imagining, is that addressed in an MBCT practice?
Yes, absolutely. Absolutely. In so many different ways, right? So the first thing you're doing is you're training attention. And when you train attention, you start to have choices about which sense stores you place your attention in. Taste, seeing, hearing, thinking, imagination, sounds outside, experiences inside. So you train attention and you begin to have a sense of agency about how you deploy and how you use your attention. That could be used in the support of imagination. My book with Christina Feldman kind of lays this out a bit more. I think that the second thing that happens then is something that I think John Teasdale has spoken quite a bit about, and in The Master and the Emissary, that wonderful book, is that idea that we are very used to living our lives in a cerebral, intellectual thinking space. But we've neglected the more experiential, the more, I don't need to say this to you, the more embodied space. And so much of imagination, of the arts, of the humanities, of connection with other human beings, of the beauty in life is experienced through the body and through our experiential practice. Take poetry, for example. And when you're able to step back and see the thinking mind and the experiential mind, you can start to dance between the two. So that when you listen to music or you are in conversation with someone, you can feel the reverberation in the body and then see, oh, you can think, oh, that was a movement from a minor to a major chord, or the person has just moved from a moment of intimacy to a moment of intellectual. So that those different modes of mind are available to us. And of course, the final part of that is then you begin to have a sense of, what's sometimes referred to as the space between stimulus and reaction. Is you begin to have a choice about what do I do here? And so, for example, you deal with a dilemma or some problem, whether that's tiny or significant, and you go, do I sit down and problem solve this and analyze this? Do I just let it be and just go to the mat and come to the breath and see what bubbles up. So you begin to have choices about how you work with things. I've got a very good friend who's an artist, who's dealing with some major issues in her life just now. And she's decided, a bit like Wendell Berry in that poem about the forest, just to be like a tree in the forest that stands steady over a period of however long it takes, months, weeks, possibly years, to see what will emerge for her. So absolutely, these practices, attention, these different modes of being, this idea of skillful, wise responding, these, I think, are absolutely potentially in the service of imagination. Whereas what you see often is reactivity and habit and lack of imagination, which will only send us further down the same routes. I think that's what's happening with education in this country. More standards, more tests, more expectations. That will solve the problem. It takes courage, though. And I hear that in your question. It takes courage, right, to step back and say, we want to do things differently.
Thank you.
Thank you. Thank you all. Thank you indeed. Thanks, Willem, for your really, as Amy mentioned, terrifying, but also inspiring and probably hopeful message. It was really great to have you from your center with us today, and representing not only your own work, but all your colleagues' work and predecessors' work, like Mark Williams and others. The Oxford Mindfulness Center is doing a really groundbreaking and significant work in this field, and we were really privileged and honored to have you with us tonight in our Mind and Life Europe community. And the recording will be available on YouTube for those who couldn't join us tonight, but will be able to watch it later. And I would just like to thank you all for your interest and engagement over here tonight. And I'm going to share a little slide, kind of an end slide with you all, and will ask my colleague Johanna to say a few words about our upcoming events. Thank you, Willem, once again.
Thank you.
Thank you very much, Willem, indeed, from all of us. And I just wanted to share with those who are still with us a few of the upcoming events, which are two of which are public events, to which you're warmly invited. So we're starting a new series, actually tomorrow, called the Eva Alumni Series, which refers to our alumni from the European Varela Awards program, those who are working in contemplative science. And so we're asking some of our more notable alumni from this program to present some of the findings and the narrative arc of their own research journey with this very significant research grant. So we'll have our first speaker tomorrow, Terje Sparby, who's a professor in Norway, and he'll be speaking about his project on first-person methods in contemplative science, microphenomenology, anthroposophy, and the stages of meditation. That's a hard one to pronounce every time. And we'll be following up with our second speaker in the series, Josipa Mihik, who will be talking about her own research as well in just about a month towards a caring and mindful schools model. And so those will both be at 6 p.m. Central European Summertime, and will also be live streamed on YouTube for those who can't join us for the live talk. And then we're actually going to be picking up with our course again next week, called the Core in Action series. We'll have our second speaker. Although this is a closed course for those who've registered, we are also live streaming this course for anyone who is interested in the series. So you can watch that on our YouTube channel as well at 6 p.m. Central European Summertime next Wednesday, September 28th. So thank you again so much for joining us, and we look forward to seeing you very soon, perhaps as early as tomorrow for our next talk. Thank you, and have a good evening.